Thanks very much for the opportunity. I'll start by acknowledging my co-authors, the first author, Amal Abdulrahman from Johns Hopkins, and the co-senior author, Millicent Adejuna from Desmond Tutu Health Foundation. And we'll recognize their funding from NIMH, as well as our Community Advisory Board and partners. So I think the last talk was a good preparation for this one. Youth living with HIV in South Africa face treatment adherence and retention challenges. I think we all know that adolescence is a time of rapid transition, developmentally, with what's going on in life, transitioning from pediatric to adult care. For those that were perinatally infected, treatment fatigue is really starting to set in by adolescents. And for those that have sexually acquired infections, which are quite a few in the South African context, you know, there's a lot of social challenges that those adolescents are facing, and all of them really are facing issues related to stigma. So long-acting injectable treatment represents an emerging option to mitigate treatment challenges if it can be accessed and reached by those who need it the most. And I think that's something that we'll continue to come back to, thinking about how long-actings can be a game changer for adolescents. So we wanted to assess contextual facilitators and barriers to long-acting treatment implementation amongst youth living with HIV in South Africa. And these data were originally intended to inform a patient preference trial amongst adolescents, including those that were non-virally suppressed, and help us specify long-acting treatment support strategies to go along with strategies to go along with the long-acting treatment in real-world implementation setting. Unfortunately, and I could say more about this later, the trial is no longer going forward because of product being rescinded, but we still have the qualitative data, and we have some discrete choice experiments that are starting right now. So these were data collected from May 23 to May 24. Recruitment was conducted in clinics in Guguletu and surrounding areas. It's qualitative, semi-structured data that were guided by the Consolidated Framework for Implementation Research and Implementation Science Framework, including the Combe Behavior Change Model. And we won't be touching much on the implementation side of things today. We'll focus more on the behavioral piece from the perspective of the beneficiaries and those around them. So we conducted 16 in-depth interviews with youth living with HIV ages 12 to 29. Some of those actually did have exposure to long-actings through the Affinity trial, and some were non-virally suppressed and didn't have any exposure to long-actings. We have key informant interviews that were conducted with 8 caregivers of youth living with HIV, predominantly parents. And then we did key informant interviews with healthcare providers, governing officials, of that nature. Transcripts were deductively coded using the CIFR framework, and the Combe model was used to guide this analysis. So the Combe model really focuses on behavior change through mechanisms. So it's this idea put forward by Susan Mishi and colleagues that in order to change behavior, there's 3 levers that you can pull: changing capability, opportunity, or motivation. And this is a summary slide of some of the key barriers and facilitators. I'm not going to walk through it all because we'll go through some of these individual aspects individually. But just to say again, this idea is that, you know, if you're hoping to change behavior and you're thinking about barriers and facilitators to behavior change, you could be thinking about capability, so competence, knowledge, and skills to be able to utilize long-actings. You can think about opportunity, so availability, things like access, and power to utilize these methods. Or you can think about motivation, so, you know, what people's desire is to change, and how to influence that. So in terms of capability, some of the barriers that emerged were that, you know, many adolescents had concerns around traveling out of the area, competing priorities, so school attendance, and obviously that's something that adolescents in particular face, having to think about clinic hours and schools. But also issues around increased clinic visits. So for those that are virologically suppressed and stable, Long-actings actually are increasing the number of visits that they need to come, increasing the number of times they need to come to the clinic and the length of those visits, particularly for those who are in adherence clubs. Lower socioeconomic status also factored in. So a few quotes: it depends on what other sort of life stuff is happening at the time with school exams, et cetera, but then there's always ways to work around it. If they miss an injection, they can get loaded again, so there are ways around it. And this is coming from a healthcare provider with experience providing long-actings to adolescents and sharing some of their experiences around the challenges. Because it will change for them now when they go away, they need to take oral medication, so it's going to confuse them because they don't want the oral medication, they want the injection, so it's going to be better if they take the injection for 3 months, you see. So this is a provider talking about some of their experiences with challenges of mobility and long-acting when it's not widely available, and thinking about, you know, how long that dosage would need to be sustainable for in order for it to be implementable in their context. In terms of facilitators from the capability domain, youth and stakeholders indicated adolescent-tailored counseling and services were important to the ability to take long-acting ART. This quote also, especially with adolescents, speaking to them like adults and giving them autonomy. You are in charge of your health as well, and we're both adults. We're making an agreement. You take your tablets, you come for your visits. This is what we can offer and what we can help, but making sure that the understanding is a two-way street and having that buy-in from them is important. So if they're struggling to come for visits for certain reasons or not understanding the importance of coming for visits, we can fix that while they're still on tablets before we get them to the injections. And this provider really did feel that until those adolescents were virally suppressed, they didn't feel comfortable thinking about long-acting injectables for them. That was not universal across the providers. There were different perspectives around that. I'll also note that amongst the 16 adolescents, youth that were interviewed, all of them did say that they preferred long-actings. And again, some had experience and some didn't. And that was a little bit of a surprise to us, and I think different than what we're seeing in some of our work that we're doing in Baltimore. In terms of opportunity around barriers, moving out of the area was mentioned as a barrier that might prevent them from continuing to receive long-acting treatment. I might move out of the area. Folks that have plans to attend university and college, this was in a low and middle income setting where you might not be able to get treatment across multiple clinics. This is something that is being factored in for those adolescents. In terms of facilitators, youth and stakeholders mentioned incentives and being free from the daily pill burden as incentives and associated stigma as enablers to uptake. Yeah, I think it would be a feeling of freedom, free from taking these tablets that I've been taking as a kid for so many years in that sense. Also, for those who are on oral treatment, it's going to be a form of encouragement to say, once I'm suppressed, this is what awaits me on the horizon. It's injectable, so let me strive for it, for suppression, so that I can graduate from tablets to injectables. So you can see that this is both an opportunity, but also, this quote also represents a motivator for adolescents to suppress. In terms of motivation, barriers that were most common was that knowledge around long-actings amongst adolescents in the South African setting is very limited. Also amongst providers that aren't actively engaged in a study involving them. So lack of prior knowledge and the anticipated side effects impact youth's motivation to initiate. And caregivers had quite a bit of hesitation as well. And the caregivers really were deferring to the providers to really guide their thinking. Yes, because the youth immune systems are different, they may not react in a good way to it. I can't say specifically because the child hasn't taken the injection, so we don't know what will happen when they continue with it. That was a parent's perspective. And again, the adolescents expressed concerns. In terms of facilitators, achieving viral suppression was reported as a motivator amongst youth, driving them to want to take long-actings, and social support was emphasized as critical. As I eat these pills, I want to be virally suppressed. And I think I will ace it and eat them until I'm virally suppressed so I can get these injectable ARVs. So again, this was a strong motivator. So in conclusion, if long-acting ART is going to be a game changer for HIV, it's going to need to reach those who need it the most. Adolescence is a time of high vulnerability, and if we're thinking about specific pockets of individuals that might be candidates to benefit from long-actings in a low and middle income setting, adolescents you know, that time period, you know, which is brief, might be a time period to consider. Future strategies, though, will need to support logistical barriers to clinical access amongst adolescents, particularly if this means more frequent visits to the clinic compared to multi-month dispensing of daily oral pills, and enhancing youth-centered counseling and reinforcing available support systems, including information for caregivers and providers around side effects. These approaches will help optimize long-acting implementation and treatment adherence retention outcomes, and ensuring that those non-virally suppressive access will be key for this to be a game changer in this context. And as a final note, I mean, I think it's just important to say that remembering and not leaving behind the populations that have been such a critical part of challenges in sub-Saharan Africa is absolutely essential. You know, it's right now, we're seeing long-actings in the US, but we're not seeing it in sub-Saharan Africa, and these have been, you know, important participants in trials. And, you know, one of the quotes from a provider that was actually optimistic, you know, they said, you know, I've been providing HIV treatment for a really long time. And I remember when they said, there's no way in sub-Saharan Africa, in South Africa, that we can treat independent of CD4. And now that's the expected standard. And I think it's just, you know, the burden and duty of all of us to continue to push for that in places like South Africa, that really this could be a game changer for individuals, but it's up to us to help force that it happens.